My brief would be to brief you on defining, screening, and staging of DKD and probably differentiating. Now, how do we define chronic kidney disease? There should be persistent, that is more than 3 months of albuminuria, or EGFR, which is less than 60 mils per minute. When this lesion, this pathology, is explained by diabetes alone with no other cause forthcoming, we presume it to be diabetic kidney disease. However, the pathological hallmark, the pathognomonic lesion of diabetic kidney disease is nodular intercapillary glomerulosclerosis, or the Kimmel-style Wilson lesions, though diffuse intercapillary glomerulosclerosis is the most common histopathologically encountered lesion. Now let's come to screening. Nowadays, we all know that diabetic kidney disease, or for that matter, any chronic kidney disease, is classified on 2 important parameters, that is the EGFR and the albuminuria grades. So when it comes to screening for diabetic kidney disease, since it is asymptomatic till advanced to a certain extent, we have to fall back on these 2 parameters, that is EGFR and albuminuria. Now, how do we estimate the EGFR? That is from certain equations utilizing serum creatinine as the analyte. That is the traditional one. The good old Cockcroft-Gault formula, which we used to use when we were students, the advantage is that it can be computed easily without any computational aids. However, nowadays, the nephrologists ask us to use the CKD EPI equation, because the problem with the modified MDRD equation is that it underestimates the measured GFR when it is beyond the threshold of 60 mils per minute. A mistake that is commonly done by many of us is that when we are dealing with pediatric patients, we use the same formula used for adults, which should not be so. We should use the modified Schwartz formula in children at least up to 12 years of age. The second analyte for screening is urinary albumin excretion, the microalbuminuria. As Dr. Shomit Ghoshal was pointing out, what would be the ideal? Whether we should do a 24-hour urinary collection for urinary albumin excretion, or is a spot morning albumin creatinine ratio. Studies have shown that these 2 have a reasonably good correlation. Therefore, it makes sense to go for the morning spot urinary albumin creatinine ratio, which is logistically much easier to estimate. But we have to keep in mind the confounding factors which can cause transient albuminuria, like urinary tract infection, fever after a heavy exercise, during menstruation, hematuria due to any other cause, a decompensated heart failure, uncontrolled hyperglycemia, and uncontrolled hypertension. Now, because of all these factors, confounding factors, it is recommended that before stamping a patient to be having microalbuminuria, one should estimate 2 urine samples, 2 to 3 urine samples in a period of 3 months, and then come to a definitive conclusion. Now, whether we would go for albumin creatinine ratio or the protein creatinine ratio, still I think it is the practice to go for the albumin creatinine ratio, though at least this study shows a good correlation between the 2 throughout the spectrum of albuminuria, from the normal albuminuric phase to even the overt proteinuric phase. As Dr. Shomit was pointing out, cystatin, it is truly a new kid on the block. It is a cysteine protease inhibitor. It is a 13 kilodalton protein produced ubiquitously by all nucleated cells, freely filtered by the glomerulus, but minded also to some extent absorbed and catabolized in the proximal tubules, though not added by tubular secretion. It is claimed to be less affected by gender, age, muscle mass, physical activity, and nutritional status as compared to serum creatinine, but there are non-GFR determinants of cystatin C2 like adiposity, dysthyroidism, and glucocorticoid use, and it is claimed to have better correlation with creatinine clearance. And I think this cartoon very in a simplistic way compares creatinine with cystatin C. Both are freely filtered, both are not reabsorbed, but creatinine is secreted by the tubules to a certain extent, and creatinine is dependent on muscle mass. So if you have a greater muscle mass in bodybuilders, or you are consuming a lot of protein, the serum creatinine will be more and creatinine clearance will be more. Similarly, in a very frail sarcopenic individual subsisting only on vegetarian diets, the creatinine would be low, and in these situations probably cystatin C is a better analyte. So this is another very interesting slide comparing head-on-head creatinine versus cystatin C. If you see the factors influencing creatinine and cystatin C, probably if you compare, the list is longer on the creatinine side as compared to the cystatin C side. Tubular is not there, not yet identified with cystatin C, but it is metabolized by the tubules to some extent. And third is the assay interference. So really, do we have any option to choose between creatinine and cystatin C? Because we have to decide, since cystatin C assay is 4 to 5 folds more costly than serum creatinine assay, and it is still not in use by the physicians, nephrologists, or cardiologists or endocrinologists. Now, this study is again a very interesting one, which has showed concordance rate in the EGFR estimated whether using cystatin C based formula or creatinine based formula in around 66% patients. Therefore, in about a third of patients, minded, there may be some discord. Right. Next, we come to staging. So we have screened with EGFR, albuminuria, whether would we use cystatin C. Now we come to staging. Now this is the Morgensen staging, which was in literature long ago, not very much popular, but I love to project these slides because this helps us understand the pathophysiology of diabetic kidney disease. The first stage is the stage of hyperfiltration, hypertrophy, followed by a silent stage, a quiescent stage, but there are structural changes in this stage, like in basement membrane thickening, mesangial expansion, podocyte loss, so on and so forth. And if we could do a renal biopsy at this stage, these histopathological changes can be detected. The third stage was the stage of incipient nephropathy or microalbuminuria. And what is important that up to this stage, diabetic nephropathy was thought to be reversible with intervention, with good glycemic control, with use of ACE inhibitors or ARBs. Next stage is the stage of overt proteinuria, from where there is a relentless decline in the albuminuria grades and EGFR. So sort of a point of no return, so to say, so far as the pathophysiology of diabetic kidney disease is concerned. And finally, the stage of end-stage renal disease, now called ESKD, eventually requiring some sort of renal replacement therapy. But nowadays, this staging, as suggested by KDIGO, is more advocated and is more frequently used by all clinicians, staging CKD based on EGFR and albuminuria grades. And with this, you can place the patient in the zone of risk and take appropriate therapeutic decisions. Lastly, a few words about non-diabetic kidney disease. Mind it, the commonest kidney abnormality in a patient of diabetes is diabetic kidney disease. But a patient of diabetes is not immune to non-diabetic kidney diseases. A patient may jolly well suffer from ADPKD, can have any form of glomerulonephritis. The pathophysiology is a little bit different, but very many forms of NDKD can be superimposed on a pathophysiology of diabetic kidney disease, and the cause is probably a more aggressive one. So in diabetic kidney disease, there is glomerular loss, and to compensate for that, the single nephron GFR rises, and there is compensatory hypertrophy of the surviving glomeruli, and because of hyperfiltration, ultimately they get sclerosed. The same pathophysiology operates in other glomerulopathies, but is much more aggravated than in diabetic kidney disease. And if a component of diabetic kidney disease coexists in a patient of, say, mesangial-proliferative glomerulonephritis or focal segmental glomerulosclerosis, this increase in single nephron GFR is furthermore aggravated. There is more of hyperfiltration injury, more of glomerulosclerosis, and eventual functional loss of the glomeruli. Diabetic kidney disease is essentially a glomerulopathy, though there may be also a component of tubulopathy in diabetic kidney disease. But in very many non-diabetic kidney diseases, there are tubulointerstitial pathology, there is tubular proteinuria. So in non-diabetic kidney disease, proteinuria generally is much more severe, much more alarming than, at least in the early stages, than in diabetic kidney disease. At this, we all know, in a typical garden variety of diabetic kidney disease, there is nephromegaly, whereas in chronic kidney disease, due to many other causes, probably except amyloidosis and diabetic kidney disease, the kidneys are small and shrunken and maybe scarred also, depending upon the etiology. To conclude, therefore, kidney disease due to diabetes is clinically silent till well advanced. Therefore, it makes sense to go for provocative screening for diabetic kidney disease and involve interventional strategies to prevent functional decline of the glomeruli, whether by use of good glycemic control, use of S inhibitors, ARB, finerenone, SGLT2 inhibitors. All these things I am sure will be discussed throughout the day. Cystatin C-based investigations may be theoretically appealing at present, but to me are practically restricted in usefulness, and we have to look at the cost effectiveness. All kidney diseases in persons with diabetes are not due to diabetes alone, and search for especially treatable non-diabetic causes for kidney disease should be undertaken if and when clinically suggested. Thank you.